Like when you write.
Blurry on my. Yeah, like right there.
Look at it.
I like.
Don't hate me if this like turns out crap.
Okay, thank you.
The main part is the audio and like
Yeah.
not anything. I know. He leaves every early. He is usually. He just gets really frustrated. Really.
Building elevator out of order. Yeah, no shit. This morning, I was in it. And I was like,
What elevator?
the one right here.
Oh, yeah.
I'm
I
shocked
went
that
on
they
it
finally,
right
literally,
now.
I swore to my worst fear is getting stuck in an elevator. That's a
got
lie.
stuck.
But,
It's awful.
no.
That's a lie.
It's awful. Okay, I feel like speaking, how do you survive like elevator falling?
I stopped
You
taking
can.
that elevator because that sign says
You pray.
don't burn electricity, burn calories. I was like,
We're talking about
I've actually been stuck in elevators.
how long? How long?
Like 10 minutes, but it feels like a
Like
lifetime.
it literally, like I heard
I feel like so will affect me to be when I was like, oh, did we lose power? Like, am I really hanging out here? But
Why is this not
it
charging?
doesn't matter.
Wait, we're on a break.
I don't know.
Are we?
I think he might be grading or.
No, we
Nah, that thing's done.
It's not posted though. It's not posted.
No.
Where the heck?
What do you mean?
My
My favorite
It's
thing.
not about you. The minute he got the bag, it says for valid.
Okay, you're weird for looking at me like that. Caramel is top tier.
Nah, Twix is actually probably the best chocolate.
I love sour.
Okay, listen,
Like
I'm
caramel
really
Twix?
doing it.
Hell no, hell no.
Caramel syrup. I love the caramel syrup. Anything
No,
caramel.
Yeah.
You really eat that Cadbury caramel? That's out there?
Why is my laptop not
Like
charging?
the purple bars or
But it's
Like this thing.
that brand felt like
No, yeah, so they have to just bring a little green and
Alright. Alright.
Oh, now it's charging.
Moving right along here, brain and cranial nerves. And yeah, so pretty long chapter. There's a lot of stuff to know. It'll take us 3 class periods to finish this chapter. I'm just gonna, you know, kind of scratch the surface on this. Anyone know what this is?
Brain.
All right, that's brain. That's easy. Which division of your nervous system is the brain in?
CNS.
CNS, central nervous system. Which division are the cranial nerves in?
PNS.
Thank you. They're in the PNS, right? And the
Glorious nerve.
and remember, what's the definition of a nerve?
It's a bundle of axons
In the
in the PN.
in the peripheral nervous system, right? So, the reason I'm belaboring that point is because there is a question about this on the next exam, lecture exam, and students always mess that up. They think, I think when they hear the word cranial, they think like, oh, inside the brain, and they think central nervous system, but the cranial nerves are part of your peripheral nervous system, just like the spinal nerves are part of your peripheral nervous system. Okay? Now, the good news for you guys is we're not going to do the cranial nerves today. There's 12 of them. They're a pain in the butt, but we do have to cover them. I guess next week probably is when I'll get to them. So here's the breakdown of the chapter. I'm going to go through the brain organization. There's 4 major areas of the brain. Anyone know the 4 major areas of the brain? Brainstem. What? Cerebrum. Cerebellum and diencephalon. All right, they're actually listed up here. Yeah. So the brainstem, cerebellum, the diencephalon, and the cerebrum. Those are the 4 major areas of the brain. Each of those areas has like sub areas that you're going to need to know. Today, I'm just going to get through the first 2, the brainstem and the cerebellum. Thursday's lecture, I'll start with the diencephalon and cover more of this information. So that's the brain organization, those 4 areas, and then they're subdivided. Protection, how's the brain protected?
Skull.
Yeah, the skull provides great protection, right? In addition, the meninges, right? The guys that you learned about that cover the spinal cord, they also cover the brain. So that's another layer of protection. Blood supply, what do you think? Do you think the brain has a good blood supply?
Good.
Yes.
Yeah, it absolutely has to, because the brain has a really high demand for oxygen and glucose, so the blood delivers that, so it needs to have a good blood supply. We'll then talk about cerebral spinal fluid. Cerebral spinal fluid is this clear liquid that kind of circulates. Well, first of all, it's made inside of the brain. It circulates around the inside of the brain and the inside of the spinal cord, but then it leaks out through little holes and it circulates around the outside of the brain and spinal cord in the subarachnoid space. So we'll discuss how it's made, where it circulates, and then eventually what the hell happens to it, and we'll go through all that. Brainstem is the first area of the brain that we'll cover. The brainstem is made up of 3 parts. Anyone know the 3 parts that make up the brainstem? Medulla, pons, and
something like
midbrain. All right, the medulla, the pons, and the midbrain make up the brainstem. In terms of importance, if you had to rate the brainstem on a scale of 1 to 10, 1 being not important, 10 being important, where would you rate the brainstem? Yeah, it's like 11, all right? The brainstem is the most important part of your brain in terms of just keeping you alive, all right? It's not the part that, allows you to think like complex thoughts, or, your personality's not located there or anything, but just like centers for controlling your heart, controlling your lungs, they're all located in the brainstem. So it's the most important part of your brain in terms of keeping you alive. Okay? And scattered throughout the brainstem is something called the reticular formation that's pretty important, and we'll discuss what that is in a moment. You can find the reticular formation, some of it's in the medulla, some of it's in the pons, and then some of it's up in the midbrain. The second part that we'll cover is the cerebellum. Where on your brain, if you had to point, where on your brain is the cerebellum? Yeah, it's on the back. It sits behind the brainstem, okay? Anyone know what the word cerebellum means?
little brain.
It means little brain. Why is it called the little brain? Because it looks like a small version of the big brain. Big brain is the cerebrum. This guy that you see here, this is the cerebrum with these big wormy things. This is the largest part of your brain. The cerebellum has those same little wrinkles and things, and it looks like kind of like a smaller version of that. So the word cerebellum means little brain, okay? Anyone know what the cerebellum is important for?
Muscle.
Muscle coordination, yeah. It's kind of like a quality control center for your muscle movements, okay? And I'll explain how that works when we get to that section. That's where we'll stop for today. We'll save the other stuff for next week. Next Thursday. All right. So 4 major parts of the brain. Brainstem consists of the medulla. You can call it the medulla oblongata if you want to, but it's okay to just write medulla like on the next lab quiz or lab practical. So that's the lowest part. Then you have the pons. The pons usually has like this little bulge on the front, so that's pretty easy to identify. And then above it is a little area called the midbrain, okay? So that's what makes up the brainstem. It's the most important part of your brain in terms of keeping you alive. Cerebellum sits behind it. You can see there are little wrinkles and folds on it that kind of resemble what you see up here on the cerebrum. So that's how it got the name cerebellum. Think motor activity, coordination, smoothing out your body movements, also helping with your posture. That's what the cerebellum is good at, okay? Diencephalon is the deepest part of your brain. It's located right in the midline, and it's kind of sitting between the 2 cerebral hemispheres. So you got these 2, here's my model. These 2 big things that you see, these are part of the cerebrum. They're called the hemispheres. There's a right cerebral hemisphere, a left cerebral hemisphere. In between them, right in the middle and really deep inside the brain, you have this area called the diencephalon. Surgically, it's a tough area to get to because it's located so deep in the brain. Now, one thing that's kind of weird about this, maybe you figured this out, what is the prefix Die usually mean? 2. But there's 3 things there. In this case, die doesn't mean 2. Die can also mean like in between or in the middle of. And encephalon is referring to the cerebral hemispheres. So this is kind of an area that's in between the cerebral hemispheres or in the middle of the cerebral hemispheres. It doesn't mean 2 in this case. There's actually 3 parts that make it up. We'll talk about these guys during the next class, the thalamus, the hypothalamus, and the epithalamus. And then the last part, the largest part of your brain, the one that I showed you on the first slide, that's the cerebrum. It's the thing with the big wormy things. It's the thing, cartoonists usually draw when they're trying to draw like a brain. They usually draw the cerebrum, right, with all the big wormy things on it. This is really our best part of our brain, or our most developed part of our brain is the cerebrum. There's no other species that have as good a cerebrum as we do, with the exception of maybe like dolphins or like, I don't know, chimpanzees or something like that. But generally, most animals don't have as good a cerebrum as we do. This is where we do all our complex thinking and conniving and plotting, all the things that we do. That's all taking place in the cerebrum. That's where your personality is. That's where you store your memories. All that stuff is in the cerebrum, okay? But nonetheless, it's still not the most important part to keep you alive. That's the brain stuff, okay? All right. So let's talk about the protection that you have. First thing are the bones. You got your cranial bones. What was the cranial bone that's located right here? Frontal. What's the one that kind of sits right behind the frontal? The parietal. What's the one that's on the side? Temporal. And then what's the one on the back? Occipital. The reason I went through those names again is to remind you of the names, but also because when we cover the cerebrum on Thursday, you'll see those names again because they use those to refer to different lobes of the cerebrum. So you'll have a frontal lobe, a parietal lobe, a temporal lobe, an occipital lobe, and those are named because they sit underneath those particular bones, okay? Now, you have the meninges too that offer protection, and it's the same setup with some slight things to mention. The dura mater is the outermost layer. It's the strongest layer. Then the middle layer is the arachnoid mater. Below the arachnoid mater, you have the subarachnoid space, which is like shown here, like in red. And then directly attached to the brain itself is the pia mater. So same kind of configuration, but one difference to mention is the dura mater actually has 2 sublayers to it. A periosteal layer, which is on the outside, and then a meningeal layer, which is on the inside. Most of the time you can't see a difference between them, they're just kind of pushed together. But in certain areas of the brain, those layers will separate. And when they separate, you have big veins sitting in those areas. And those big veins are called the dural venous sinuses. These dural venous sinuses are there to collect the blood after the brain has taken the oxygen and the glucose out of the blood. They're there to collect that blood. And eventually all those dural venous sinuses will take the blood down your neck using your jugular vein and then bring it back to your heart. Okay? Now, another thing that the dura mater does that's worth mentioning is it kind of creates dividers within your brain that help to organize the brain. And of course they have crazy names for these dividers, but let me tell you where they are. So the first divider runs right in the mid-sagittal plane, and it's called the falx cerebri. So it's going to divide the cerebrum into the right and left hemisphere. So if you look at this model, that's really not a good view to look at it on, but if you look at somebody head on, right in the midline would be the falx cerebri, and it's dividing the cerebrum into a left hemisphere and into a right hemisphere, okay? Similarly, there's something called the falx cerebelli that does the same thing for the cerebellum. So if I flip this around on the back, there's the cerebellum, and running right in the middle between the left and the right lobes would be the falx cerebelli. And then the last one is kind of the oddball because it runs in the transverse plane. It's called the tentorium cerebelli, and it separates the cerebrum from the cerebellum. So if you look on the back, up here is the cerebrum, and then down here is the cerebellum, and there's a fissure there, called the transverse fissure, and in that fissure, you have the tentorium cerebelli, kind of acting like a shelf or a divider between the cerebrum and the cerebellum. Okay. All right. Now, blood flow to the brain. You already know that it's good blood flow, and that's because there are 4 main blood vessels that are going up to your brain. There's a right and left internal carotid artery that kind of go up the front of your neck. And then in the back of your neck, there's a right and left vertebral artery. Okay? So you can see it there. And it's those vertebral arteries that are actually running through, you can see it on the diagram here, that are running through those foramen that are in the transverse processes of your cervical vertebrae. Remember, cervical vertebrae had 3 holes and not just 1? Those holes on the sides are for those vertebral arteries to run up towards your brain. Okay? So there's the arteries. Now, in terms of the veins, again, you're going to have these big collecting veins called dural venous sinuses that collect the used deoxygenated blood, and then eventually they bring it down into your internal jugular vein, which then will carry it back to your heart. There's a lot more I could say about the blood flow to the brain, but we'll cover arteries and veins and stuff more in A&P2 when we do the circulatory system, but that's like a good sort of intro to it. Now, the reason why the brain has to have a good blood supply is because it uses a disproportionate amount of oxygen and glucose compared to how big it is. The brain's not all that big, but it uses about 1/5 or 20% of the body's oxygen and glucose, okay? So it definitely has a high need for oxygen and glucose. And the problem is that neurons are not flexible in terms of what kind of nutrients they will use. Neurons only use glucose to make ATP. They won't use other possible energy sources like lipids, or they won't use, other types of carbs or things. They rely almost solely on the glucose to make their ATP. So they need a steady supply of it, which means they need a lot of blood vessels to deliver it. The other reason too that they need a lot of glucose being delivered is because they don't store up any glucose for future use. They're not like your skeletal muscles that store up glycogen to give them kind of a quick supply of glucose when they need it. Neurons don't do that. So you got to have good blood flow. If you block blood flow to your brain for just 1 to 2 minutes, you will notice, don't try this, you'll notice people will start acting screwy, right? They may start staring off into space. They may start slurring their words. They may not be able to move. One side of their face may start to droop. They may not be able to move one side of their body, okay? And if blood flow gets, if it's just temporary, if it only lasts for a few seconds and then they're back to normal, there's a name for that problem. Anyone know what the name of that is when you kind of have, what'd you say? That's not a stroke, not when it's a temporary blockage. TIA, somebody said it, it's a TIA, okay? A TIA is a temporary blockage. That stands for a transient ischemic attack. The word transient means like sort of temporary. The word ischemic means like low blood flow, not enough blood flow where you can support like a tissue. And then attack just means it kind of came on suddenly. So a TIA is a temporary blockage. And, for example, you could be out with a person and they're fine 1 second, then all of a sudden out of the blue, they just look off into space, they start slurring their words, but then 10 to 15 seconds later, usually, they're like back to normal, right? Look on YouTube, there's actually lots of videos of people, there's like a video of some like newscaster that had a TIA while she was on the air or something like that. If you're ever out with like an older, usually this is gonna happen to older people. You don't see TIAs usually in young people. You could though, but if you're ever out with like say your grandma or grandpa or something, and then they suddenly stop talking, or they look in one direction and just stare for a few seconds, or their side of their face just doesn't move, they're still trying to talk, and then it goes away, they probably had a TIA, all right? If it only lasts for a few seconds, they probably had a TIA. Should you do anything with them if that happens? Or should you just say, oh, they're back to normal and not do
Go to the
anything?
hospital.
Yeah, you should take them to the hospital, right? They're gonna be grumpy, you know how grandparents are, right? They're gonna be like, I don't wanna go, you know, I'm fine. Take their ass in, all right? It doesn't, take them in because it's been well documented that when you have a TIA, there's a very high likelihood of having a full-blown stroke in the next 24 hours. A stroke is when you've interrupted blood supply for a longer period of time and you've actually destroyed brain tissue. With a TIA, no permanent damage has been done yet, but it strongly suggests that they're going to have a full-blown stroke in the near future. So if you take them in after the TIA, they can do stuff for them in the ER. They can give them like clot-busting drugs that help to break down clots that they might have that are causing a blockage. And you know, you might end up saving their life or at least preventing a serious stroke if you do that. Don't listen to them. I feel fine, it was just temporary. Take them in, okay?
I've seen that happen before.
You have seen it?
Yeah.
Yeah.
I was getting ice cream and there was a family with an older woman, and she was talking to them, and all of a sudden she just like, they were like, something's going on, and I saw her face is like drooping, and then she's like, I'm fine. So they called the ambulance.
Oh, they
and
did,
They
good.
brought her into the hospital.
Yeah, that's what you should do.
Can I ask you a question?
Yeah.
How are these like people able to hold their breath in for that long amount of time? Like David Blaine or like those magicians that hold their breath for like 10 minutes or whatever. It doesn't magic.
No, how are they able to hold
Like
their...
underwater? Like I've seen them like be like dropped in underwater.
Yeah, I mean, their conditioning, I think it's more of a conditioning of their, you know, their respiratory system. There might be opening up more alveoli. I mean, I honestly don't know all the physiologic changes. It's real. They can hold their breath that long. You know, they'd be deprived of oxygen, right? But they would still technically have all the glucose. So it's not a deficiency of like glucose, but yeah, how they're able to go, you know, you're not technically stopping blood flow to the brain. You're just not creating new intake of oxygen. I mean, I think there's probably some maximum limit, so long as you have the blood flowing, where you have enough oxygen in your body from one big inhalation that it could actually last for, you know, many minutes probably, right? Just so long as you're not physically blocking off blood flow. Put David Blaine underwater and let me tie off his neck, and let's see how long he lasts that. All right? Not so special now, are you, David? All right. All right, blood-brain barrier. This is a thing that's there to prevent potentially harmful substances that might be in your blood from getting into your brain tissue. Okay? Throughout your body, we'll cover this in EMP2, but throughout your body you have little blood vessels called capillaries. And most of the capillaries in your body have very thin walls, and it's easy for stuff that's in your blood to pass through the wall of the capillary and get into the tissues. Okay? That's how it is most places in your body, but the brain is an exception. The walls of the capillaries are harder to get through, and that's what this blood-brain barrier is. And the purpose of it is so that if there's a harmful chemical or something, or bacteria or virus that's in your blood, that you're preventing it from getting into your brain tissue where it could cause damage. So, what makes up the blood-brain barrier? First of all, you have tight junctions between the cells that make up the wall of the capillary, okay? You'll learn this in AMP2, but every blood vessel, the wall is made up of something called endothelial cells. And in most places in the body, there's little clefts or spaces in between those endothelial cells where things that are in the blood could technically kind of squeeze their way in between those cells and get out into the tissue. Not in the brain. Instead, there are tight junctions holding those endothelial cells together, which makes it really hard for anything to be able to squeeze out of those blood vessels and get into your brain tissue. That's number one. Number two, remember your setup from chapter 4. Usually after an epithelial tissue, then it'll be sitting on a basement membrane and then there'll be connective tissue. In this case, the endothelial cells of the blood vessels sit on a basement membrane, and that basement membrane happens to be much thicker in brain capillaries than it is in other capillaries throughout the body. So that also is making it harder to pass through. And then number 3, and this was mentioned in chapter 12, you have a type of neuroglia called an astrocyte. And these astrocytes have projections that go out and they surround the blood capillaries. So that's providing yet another layer that things would have to pass through to be able to get into your brain tissue. Okay? Obviously the good stuff is able to get through. Oxygen doesn't have any problem. Glucose can get through. But other kind of substances like creatinine, urea, these are like some breakdown products of like amino acids, ions, they don't get through. Proteins, which are usually huge, they don't get through. And drugs, which are often based on proteins or at least have a fair amount of size to them, they have a hard time passing through. For example, most antibiotics don't pass through the blood-brain barrier, which means that when you have a brain infection going on, it can be really tough to cure that, to treat it with antibiotics because they won't cross the blood-brain barrier, okay? So that's something to think about. The other thing too is pharmaceutical companies have to consider the blood-brain barrier anytime they're designing a medication that's supposed to work on the brain. So if you're in the business of making antidepressants or antipsychotics or anti-anxiety drugs, any of those drugs that have to get into your brain, they have to be specially designed so that they cross the blood-brain barrier, okay? Or else they won't be able to help you out, okay? Also, all of your illicit drugs, right? Cocaine, meth, pot, whatever, they all cross the blood-brain barrier, all right? Those drug dealers on the corner, they're not stupid, right? They want a drug that crosses the blood-brain barrier, you know? A drug dealer that advertises drugs that don't cross the blood-brain barrier, they're gonna go out of business, right? Nobody's gonna go to that guy, right? So they all pass. Now, during a trauma situation or other brain diseases, you can get a breakdown of the blood-brain barrier so that it becomes more permeable and things that ordinarily wouldn't be able to pass can start to get through. But, again, under normal circumstances, it's pretty impermeable. All right, any questions about the blood-brain barrier? All right, moving right along. Actually, at this point in the lecture, I think is when I gave my other class a break. Do you guys want like a 5-minute break? They want me to keep going. See, keep going. See, this is the power of democracy. On election day, we're demonstrating what it is to vote. Good. Yeah. All right. All right. CSF then, cerebral spinal fluid. I'm just gonna keep trucking along, and maybe we'll get out a little bit early. CSF. It's a clear liquid. CSF is made deep inside your brain in these areas, these cavities that are called ventricles. So this is a side view of someone's brain, and these things in blue are these big cavities that are referred to ventricles. Now, before you took this class, if I said the word ventricle, what organ in the body would you probably think of?
Heart.
The heart, okay? And definitely that's what ventricles are best known for, right? But just so we're clear, the ventricles in the heart, they are able to squeeze and pump blood. These ventricles, they don't squeeze, they're just cavities, okay? Why they had to call them ventricles, I don't know, but they did, and so we just kind of roll with it. So this is what they look like from the side. There's 2 of these lateral ventricles. Each one of the lateral ventricles is going to be in the cerebral hemisphere. So you'll have one in the right hemisphere, one in the left hemisphere. And then they kind of meet in the midline, and they connect up with this thing called the third ventricle. So third ventricle is right in the middle of the brain. And then the third ventricle is connected down a little bit lower with the fourth ventricle, which is also right in the midline of the body. Now, in the fourth ventricle, there are actually some holes that allow the CSF to get out of the inside of the brain and actually get on the outside in that subarachnoid space, okay? Also in the fourth ventricle, if you look here, there's a continuation. You see that blue line going down there? That's actually the central canal of the spinal cord, right? That little hole that's in the middle, that's connected to the fourth ventricle. So what I'm gonna do at this point is I'm gonna draw my version of the ventricles. I like to do, this is a sideways view, but I think it's easier to see like looking at head on. So let me do that and show you this. So this is a front-on view of the ventricles. And let me label this crazy thing. So these two guys here would be the lateral ventricles. One in the right hemisphere, one in the left hemisphere. This guy in the middle here, that would be the third ventricle. And then this guy, a little further down, would be the fourth ventricle. And then this, continuing down, that would be the central canal of the spinal cord. Okay? I'm going to add to this picture, but that's enough for a second. I'm going to start adding to it. So let's talk about where CSF is made, how it's made, and then where it circulates. So the answer to where it's made is it's made at these little spots that are in the ventricles called choroid plexuses. And it's made by, if you remember back to chapter 12, it's made by a type of glial cell called an ependymal cell. So let me draw this in on my diagram. So sitting in the ventricles, you'd have these choroid plexuses. Now, just to keep this kind of simple, I'm just going to draw the choroid plexuses in the lateral ventricles, not the other ones. So these would be the choroid plexuses. And inside the choroid plexuses would be where you'd find the ependymal cells. The ependymal cells, how do they make the CSF? In one sentence, by filtering the blood. Ependymal cells filter the blood. They keep out all the big things. They keep out the red blood cells, the white blood cells, all the big things of the blood, that stays in the blood. But like the liquid part, the plasma, is what essentially becomes the CSF. Okay? So I'm just going to add to this. Choroid plexuses, I'll just say ependymal cells here make CSF by filtering blood. Okay? So that's where the CSF is made. And the question is, how does it circulate? And so let me walk you through what's shown up here. So assuming that we're talking about some CSF that's been made inside the lateral ventricles, these CSF would flow into the third ventricle like this and like this, using these little passageways that I didn't label, but I will label them. They're called the interventricular foramina. So these guys here, it's kind of a long word there, that's the interventricular foramina. All right? Now, once the CSF is in the third ventricle, where does it go next? From the third ventricle, it goes through this narrow passageway called the cerebral aqueduct, which is this thing here. Okay? That's the cerebral aqueduct. And it's actually pretty famous. I'll tell you why in a second. For oldsters like me, it had a more regular name. It used to be called the Aqueduct of Sylvius. You're welcome to use either names like a practical. So the Aqueduct of Sylvius. It's also known as the Aqueduct of the Midbrain. So it goes by a couple of different names. All right. After the cerebral aqueduct, then you're in the fourth ventricle. So the CSF is continuing on like this. It's now in the fourth ventricle. Now, once it's in the fourth ventricle, it kind of has options. One option is to just continue on and go into the central canal of the spinal cord, like that. The other option, though, is in the fourth ventricle are where you have these holes that allow the CSF to move out of the inside and get into the subarachnoid space, which is on the outside of the brain and spinal cord. Of course, in standard A&P fashion, they couldn't just call them holes. They had to use a more complicated word. They call them apertures. So these are the holes, the median aperture and then the lateral apertures. And just to kind of draw them in, they'd be on the fourth ventricle. And they're allowing the CSF to move out and get into the subarachnoid space. So out here, I'll just say subarachnoid space. Okay? Now, the question is, great, these guys are making CSF. CSF is going through these passageways. But then the question becomes, well, what happens to that CSF eventually? You can't just keep making it. It's got to eventually go someplace. And the answer is, it goes back into the blood. It gets returned back into the blood. It came from the blood by being filtered from the blood. It circulates, and then ultimately, it goes back into the blood. How? By using these little things that are called arachnoid villi, which it's kind of hard to show it on my diagram, but I'll show it here, and then I'm going to go back a few slides to show you so you can visualize it. As the CSF is circulating through the subarachnoid space, eventually it'll come to little outgrowths of the subarachnoid space called arachnoid villi. You can see one like there, and like there, and like there. And these little guys, they project into those big veins that I mentioned before, the dural venous sinuses. So as the CSF goes into those spaces, it'll cross through the wall of the arachnoid villi and then be picked up by these big veins. So it's getting returned back to the blood. It came from the blood, it circulates, and then it gets returned back to the blood. Here's a better picture that I showed you before. I didn't mention it, but here's a better picture of those arachnoid villi. So notice the thing in red is the subarachnoid space, and then these things that are in pink that are kind of projecting out here, those would be the arachnoid villi. And as the CSF goes through the subarachnoid space, it'll go into these arachnoid villi, cross through the walls, and that's how it gets into those big veins. Okay? So that's how it's made, how it circulates, and then how it gets returned back to the blood. All right, now, whoops, spoiler alert. So, scare you. Normally, CSF is made at the same rate. Well, it should be returned back to the blood at the same rate that it's made when it's taken from the blood. So, and that rate is about 20 milliliters per hour. So, as long as those arachnoid villi are returning the CSF back into the blood as fast as the choroid plexuses are making it, everything will be fine. If, however, the choroid plexuses make it too quickly, or if the arachnoid villi just aren't doing their job to return it back to the blood, then CSF can start to build up in the brain, and that problem is called hydrocephalus. So one cause of hydrocephalus is by having these two guys not be in sync. Okay, the arachnoid villi and the choroid plexus. That's not the most common cause of hydrocephalus. The most common cause of hydrocephalus is simply a blockage somewhere along this pathway. And the most common place to get a blockage is at this, and this is part of the reason why it's famous, is at this cerebral aqueduct. The cerebral aqueduct is very narrow to begin with. And all it takes is some brain malformation, a tumor, or something growing in the tissue around those areas to basically cause a blockage right here. And if that happens, unfortunately, these choroid plexuses, they're going to still make CSF. They're not going to stop making it. So as they make that CSF, the lateral ventricles, the third ventricles, they start to fill up and they become like these huge water balloons because you can't get past that blockage, which would allow you then to get into the subarachnoid space, which would then allow you to return it back into the blood. Okay? So that's the usual cause, a blockage at the cerebral aqueduct. Could be a tumor, could be some brain malformation in that area. It really doesn't take much because it's a relatively narrow passageway to begin with. Hydrocephalus usually occurs in kids. It's like congenital, so they have some congenital malformation in that area of the brain that causes a blockage. Symptoms, you can see a swollen head. I already, if you looked quick, you saw that. I'll show you it in a second, but you can definitely see a swollen head. Tell me, okay, you can get hydrocephalus in an adult, you can get it in a kid. In an adult, their head's not going to swell up, but in a kid, a young kid, their head will swell. Why is that?
Because the
Right, because the bones haven't fused yet. You still have those fontanelles, the sutures haven't come together yet. So you will get a massive head, potentially, depending on how early you catch the problem in a child, but you won't get it in an adult. It's actually, even though it looks kind of scary when you see a kid like that, that's actually a good thing. Why is that a good thing if their head's getting big like that?
You can identify what blockage could be.
Well, no, that's not exactly where I was going with it. What does that mean? If their head's expanding as the fluid's building up, then not so much pressure is being put on what?
The brain.
On the actual brain tissue, right? In an adult, you got this hard skull that's not expanding. So as fluid builds up, the only alternative is for the brain tissue to get compressed, and that can lead to severe brain damage. In a kid, at least their whole skin and bones are stretching to at least alleviate some of that pressure that would be on the brain, right? So that's why it's actually kind of a good thing, even though it looks weird, right, and kind of crazy. What other symptoms can you see? Like, you may not, obviously, if you see a kid that looks like the one I'm about to show you, you'd be like, oh my God, he's got hydrocephalus. But sometimes it's more subtle. You have 2-month-old, 3-month-old, they're vomiting. Sleepiness and irritability, that's pretty non-specific. Anybody that has kids, like newborns and things, that kind of crap happens all the time. Do they all have hydrocephalus? Absolutely not. They usually got something else going on, but that could be a symptom. Headache, they're not going to obviously tell you about that if it's a young kid, but they'll, cry or whatever. Nausea, they're not going to tell you about that. One thing you can pick up on, though, is for whatever reason, when the pressure comes on some of the nerves that go to the eye muscles, it leads to a downward deviation of the eyes, and that's kind of a key feature. So let me show you that picture that I had up before. Here's a child with hydrocephalus. And notice the eyes kind of going downward, right? It looks like they're looking like this, right? That's like a key feature of it. So that's something that you could detect. So what can you do for people that have this? 2 things: VP shunt and an ETV. Anyone know what either of these things stand for? Anyone know what a VP shunt is? You're like, oh yeah, just spent last night reading about VP shunts. No, a VP shunt stands for ventriculoperitoneal shunt. Okay, that's what the V and the P come for, ventriculoperitoneal shunt. This is a operation where they drill a hole through your skull. Don't freak out, they usually have to do that when they're doing brain surgery, right? They drill a hole through your skull, and then they find a very small tube, a catheter, and they thread that tube in through that hole, and using various neurosurgical techniques and whatnot, they put the tip of that catheter in one of these dilated ventricles. Okay, again, these are going to be filled up with extra CSF. They put the tip of that catheter in there. Then what they do is they actually tunnel, if you can imagine it, out of the skull, and in the subcutaneous space, they create a tunnel or a passageway for that catheter to go down like the patient's side of their head, down their neck, and then all the way down their abdomen, and then the fluid ends up being dumped into their peritoneal cavity, which is in their abdomen. That's why it's called a ventriculoperitoneal shunt. And that little catheter has one-way valves in it so that the fluid can't go backwards and go into the brain. So as fluid starts to build up, it will naturally then go through the catheter, drain down all that thing, and then dump in the abdomen. And that alleviates the pressure.
So the catheter is in one
One of the ventricles. The tip of it is in one of the ventricles.
Okay.
Yep.
So they only need to assess the issue in like one of the main ventricles, or is there like a difference in
Well,
between
they're
being
all
in one
three
versus
of
another?
Yeah, no, all three of the, I mean, I'm not a neurosurgeon. There probably is a better answer to your question, but all three of them are interconnected. So in theory, if you just got it in either of the two lateral ventricles or the third ventricle, it should be able to drain it. Yeah, yeah.
Is it genetic or caused by something, or is it just random?
Yeah, no, it's there is a genetic link to it. I don't know how strong a link is it to it, but there is a genetic link to it. Yeah.
So it just kind of happens, though.
Yeah, it happens when something in the midbrain, which we'll talk about in a second, is located in this area. So if there's any kind of malformation of the midbrain, if there's a tumor growing in the midbrain, it can easily compress that passageway, and that's how you get it. Yeah. Yeah.
And all the CSF that gets dumped into the abdomen, does it ever find its way back? Up there again, or
Well, as it gets dumped into the abdomen, it will be naturally absorbed like through the wall of the peritoneum. Eventually it gets returned into your blood anyway, which is the original spot. That was the original goal anyway. So yeah, it's ultimately getting returned back to the blood. It just takes a little while longer. Now I had a quick anecdote I was going to tell you about a VP shunt. I'm just going to tell you this quickly. I used to work, don't judge, I used to work at Pizza Hut when I was in medical school driving like delivery cars. All right, don't judge. That's nothing to be ashamed of, right? Anyway, my manager, as soon as I got there, I noticed his forehead was a little bit like large. It wasn't huge. I mean, he was, no. I mean, it wasn't like, oh, wow, that's a large head. But I mean, it was just a little bit bigger. And anyway, at that summer, I was also doing, just coincidentally, I was doing a rotation with a neurosurgeon. And I told him that, and he's like, oh, well, when I was a kid, I actually had hydrocephalus, and I had one of these VP shunts put in. I said, oh, that's interesting. Anyway, fast forward a few weeks, and I found out this guy that I was rotating with, this neurosurgeon, was actually going to do a VP shunt procedure. I swear that every time I tell this, I feel like I'm telling a lie. I swear to God it's true. I said to the neurosurgeon, would it be okay if, I didn't use these exact words, but would it be okay if my Pizza Hut manager came and scrubbed in on the case so he could watch this, because he had it when he was a kid. I thought it'd be interesting for him. And to my surprise, he said that'd be fine. He didn't actually have him like scrub and get sterile, but he got to be in the operating room to like watch it. Anyway, we're standing in there, I'm in there, my Pizza Hut manager's in there, the neurosurgeon's in there doing his thing, and they do the drilling part through the skull, right? And I look over at my Pizza Hut manager, and he's okay. He's kind of like just kind of processing it, kind of watching, what's going on. But then they get to the part where they have to tunnel that passageway through the what they have to do is they have to take this like plastic ramrod and go like this to create a passageway that goes through the skin all the way down to the abdomen. When they did that, I looked over and he just went, he just dropped. So I felt really bad about the whole situation. But anyway, that was it. I think I forget what happened. I think what's that?
You got fired for that?
No, he didn't get fired for that. But it was just a crazy.
When is the shunt taken out? Is it ever taken out?
No, it can stay in for a while, is my understanding. Sometimes it stays in permanently, but I mean, on rare cases, they might take it out if the problem resolves itself. If whatever the blockage was caused by, if it was a tumor and they were able to actually get the tumor out or something like that, then they might take it out. But I think for the most part, it's like a permanent thing. Okay. And one of the problems with that is that shunt can become blocked sometimes, and then they have to go in and sort of revise it or clear out the shunt so that it, because So if all of a sudden somebody started acting kind of screwy again, neurologically, it might be a suggestion that that shunt got blocked and they'd have to reevaluate it and take them back to maybe revise it. Because of that, they did do this other procedure. You don't have to know this, but this is called an endoscopic third ventriculostomy. With this procedure, they go in, and it's a little bit simpler than the VP shunt. They don't put a long tube down. In this procedure, they just go in and they make a small incision in the third ventricle, and they create a direct connection between the third ventricle and the subarachnoid space. So they're basically doing kind of this thing, but they're creating it up here. And with that, you don't have to put any long tube in or anything like that, and so you don't run the risk of some tube getting blocked or anything like that. So I think this is probably more of what they do today, but they still may do the VP shunts.
Does it cause delays, hydrocephalus?
Does it cause developmental delays?
Yeah.
It can. It's if some damage has been done, yes, it could certainly cause a delay. But if they manage to catch it early enough, they can be totally fine and not have any problems. I mean, my Pizza Hut manager, aside from the fact that he was working at Pizza Hut, seemed to be okay, right?
Dr. Brown, what does ETV stands for again?
Endoscopic third ventriculostomy. Do you want me to write it?
No.
All right. Yeah, I'm not going to test you on it. Yeah. All right. Let me talk about the brainstem, though. This is the first part of the brain that we're going to cover. Then we'll do the next one. So the brainstem, most important part of your brain to keep you alive. 3 parts. Lowest part is the medulla. Next part is the pons, and then the highest part is the midbrain. The medulla is beginning at the inferior border then of the pons, and it extends all the way to the foramen magnum. So right about here would be the foramen magnum. So if you're above the foramen magnum, you're in the medulla. If you're below the foramen magnum, you're in the cervical spinal cord. Okay. So if you were to look at a sample of the medulla underneath the microscope, it's going to look a hell of a lot like the cervical spinal cord. All right. It's not like some magic change happens when you go from here to there, okay? It's really just that anatomical hole as a boundary. When you're above it, you're in brain. When you're below it, you're in spinal cord. So what that means is if you look in the medulla, all of those crazy tracks that you had in the spinal cord that are going up if they're sensory or down if they're motor, they're all going to be someplace in the medulla too, right? They have to be, right? Because eventually they have to go up to higher parts in the brain. The medulla is most famous for the nuclei that are in it. Again, what's the definition of a nucleus? A collection of neuron cell bodies in the CNS, the central nervous system. So the nuclei that you have in the medulla, those are the ones that are going to help keep you alive. Those are the ones that control your heart, control your lungs, your breathing. So that's kind of what the medulla is best known for, are these vital centers. And we'll talk about those in the next slide. If you look at the front of the medulla, there are these 2 bulging sections that they have on the front of it. So again, on my brain model, it'd be looking like this, and then down here we're talking about, there's the medulla down there, so that's those bulging parts. Those are called the pyramids. I have no idea why they call them the pyramids. I don't know if the person here was from Egypt or liked Egypt or whatever. I have no idea. They don't really look like pyramids to me, but whatever. If you could look inside the pyramids, you would find the corticospinal tracts. Those are the tracts that start in the cerebral cortex, and they ultimately go down to your spinal cord, and they control voluntary movements of your arms and your legs and all that stuff. As they go down, they pass through these pyramids, and midway in the pyramids, there's a crossing over spot called the decussation of the pyramids. This is another reason why, if you have a stroke on the right side of your brain, what side of your body's paralyzed? Left, right? There's lots of opportunities to cross sides for neurons. I mentioned in the spinal cord you had the gray commissure, the anterior white commissure. That's one spot. But then here's a crossing over spot up in the medulla, right, in your brain. So lots of places where you can cross sides. The term decussation literally means to cross over, okay? Now, what the medulla is most famous for are the nuclei that control vital functions. So let's go through them. First, and arguably maybe maybe not the most important, the breathing's pretty important too. The first though is cardiovascular center. That's going to control how fast your heart beats, and then also how forcefully it beats, like how much what we call contractility there is in the heartbeat. In addition, it's also going to control the diameter of your blood vessels, right? You'll learn this in A&P2, but most of your blood vessels have a little layer of smooth muscle in them, and you can, by stimulating or not stimulating that smooth muscle, you can cause your blood vessels to dilate, or you can cause them to constrict. That's all being controlled by this cardiovascular center, okay? Medullary rhythmicity center is what sets your basic breathing pattern, like how many seconds you inhale for, and then how many seconds you exhale for. So it's super important for breathing. So these are probably the two most important centers that are in the medulla, but you have some other centers too. There's a vomiting center that controls vomiting, a swallowing center that controls swallowing. They call it, this is just a fancy word for swallowing, deglutition. There's a sneezing center, a coughing center, a hiccuping center. All those centers are located someplace inside the medulla. The other thing about the medulla that you should know is it's going to be the starting point for some of your cranial nerves. Now, we'll talk about the cranial nerves probably on Tuesday next week. Cranial nerves are a pain in the butt. There's 12 of them. There's lots of details to know about each one. One thing you should know about the cranial nerves is where they originate. And in this case, and the other thing you should know about cranial nerves, make sure you know your Roman numerals. What's this number here? 8. What's that number? 12. So cranial nerves 8 through 12 actually originate someplace in the medulla, okay? This is an underside of the brain, okay? So this is a view. You took the brain and you tilted it like this and you looked at the underside. That's what you're seeing over here. And in general, there is a method to how they number the cranial nerves. As you go in from anterior, which would be up at the top here, or up at the top here, those are going to be like cranial nerves 1 and 2. And then as you go towards posterior back here, you get to 12. So there is a method to how they name them, but we'll get more into that next week. Next is the pons. Pons literally means bridge. The reason it got that name is because lots of neurons that are going up to higher places in the brain will stop off in the pons. Neurons that are coming down will stop off in the pons. They may then go into the cerebellum, which is just behind the pons. Or neurons coming out of the cerebellum will stop off at the pons and then go up or go down, depending. So somehow it got this name, the pons, which means bridge. Now, the pons also has its own nuclei that control vital functions. So specifically, there are some connections in there that are important for coordinating voluntary skeletal movements. The pons has a lot of communication with the cerebellum, and as we talk about in a second, the cerebellum is kind of a quality control center for your body movements. So the pons kind of controls the signals as they go into the cerebellum or as they come out of the cerebellum. The pons also has a breathing center, 2 breathing centers called the pneumotaxic and the apneustic areas. And they're going to help out the breathing center that's in the medulla. The medulla is the most important one. It sets the general, rate of your breathing, how long you inhale, how long you exhale. But sometimes these other 2 areas, the pneumotaxic and the apneustic areas, they'll make adjustments to that. Okay? We get way more into these areas in A&P2 when we talk about the respiratory system. And then lastly, you should know the cranial nerves that originate in the pons. And they're going to be, what's that number? 5 through 8. So 5 through 8 originate in the pons. If you recall from the previous one, also 8 comes a little bit from the medulla, so it kind of crosses over to both the pons and the medulla. Last part of the brainstem and the highest part is the midbrain. The midbrain is where the cerebral aqueduct is going to be. That's why the other name for the cerebral aqueduct is the aqueduct of the midbrain. You can actually, it's hard to see. I can kind of see a little edge there that's probably the cerebral aqueduct, but it's a little tricky to see there. On the front of the midbrain, so again, if you took this model, it's kind of hard to see because the midbrain is so high, but if you looked up here at the anterior part of the midbrain, you'd see these bumps here called the cerebral peduncles. Inside those are going to be some of your important motor tracts that some of them you've already heard about in the spinal cord chapter. So the corticospinal tract, that starts in the cerebral cortex, the cerebrum. It goes down, but as it's going down, it passes through these cerebral peduncles. Eventually, it'll reach your spinal cord, and that's going to do voluntary movements of your arms and your legs. The corticobulbar tract starts in the cerebral cortex. It goes down, passes through the cerebral peduncle, and then it stops actually in lower parts of the brainstem. And that's going to do voluntary movements of like your facial muscles when you smile or frown or things like that. And then the corticopontine tract is a tract that starts in the cerebral cortex and it goes down through the cerebral peduncles, and then it stops in the pons before then having signals sent into the cerebellum. Okay. If you spin the midbrain around, you're going to see 4 bumps on the back side of the midbrain. The back side of the midbrain, the posterior part, they call it the tectum, and they specifically refer to those bumps as the corpora quadrigemina. Corpora means, you want to know what corpora means? What's that? Horse related? No, it's not horse related. Yeah. No, not roof. No, it just means body. Yeah, corpus means like body. So corpora is body. And then what does quad mean? 4. And what's Gemini mean? Who's a Gemini in here?
Twins.
Twins. So this is the 4 twins. I don't know why they got that crazy name, but that's the name for those 4 bumps that you see here. They call that the corpora quadrigemina. Unfortunately for you, somebody did more research on them and found out that the 2 bumps at the top have a different function than the 2 bumps at the bottom. So they had to then separate out the names. So the upper 2 bumps are the superior colliculi, the lower 2 bumps are the inferior colliculi. All of these bumps deal with reflex movements of your head, your eyes, and your body in response to different stimuli. But the stimuli is different for the upper 2 versus the lower 2. The upper 2, it's going to be a reflex movement to visual stimuli. So when you're looking at something in your field of view and you see any kind of movement in your field of view, we have a built-in reflex where we'll turn our body and our head and our eyes and look at that thing that was moving in our field of view. That reflex is governed by the superior colliculi. We also have a reflex where if we hear a sudden sound, boom, right? You turn and you look where that sound is coming from. That's governed by the inferior colliculi. So they do in response to auditory stimuli. Okay? You also have nuclei that are in the midbrain. They're not quite as important as the ones that are in the medulla and the pons in terms of just keeping you alive, but they're still important. One type of nuclei is called the substantia nigra. It's important for controlling those subconscious muscle activities. Remember I told you when you walk, what do you do with your arms when you walk? Yeah, without thinking, you're doing this with your arms. If you have damage to that area, you may lose some of these subconscious muscle activities. For example, with Parkinson's disease, there's often damage to this area, and when those neurons are lost, you'll lose some of those things. And in a Parkinson's patient, it's pretty common for when they walk to kind of walk like this, okay, without their arms moving, okay? Red nucleus, that's also helping to control muscle movements. And then lastly, the midbrain is going to be the origin of, what's that number? 3 and 4. So cranial nerves 3 and 4, they originate in the midbrain. Now, lastly, before we leave the midbrain, I just want to mention this reticular formation. The reticular formation is an area that extends through all three parts of the brainstem. So a little bit of it will be in the medulla, a little bit will be in the pons, and then a little bit will be in the midbrain. And this reticular formation, it got its name because someone thought it looked like a net. That's what the word reticular means, like a fishing net. I don't really see it, honestly. I don't know how they came up with that, but it does kind of have a hazy sort of look to it. Like if you took a slice of a specimen and did like a microscope stain on it, it does kind of have a hazy appearance to it. And the reason why it looks a little bit weird is because it's actually a combination of gray matter and white matter. There's going to be neuron cell bodies in there, which are going to be usually unmyelinated, so they're going to be gray matter. But then you're also going to have small bundles of myelinated axons that's going to look white. So when you mix it all together, it gives you kind of this hazy appearance, and they call it the reticular formation. Now, there's a part of the reticular formation that descends downward that's going to be motor, and that part is important for regulating your muscle tone. That muscle tone is like how much contraction is in your muscles. Even when you're not using them, there's a little bit of contraction just to get them to the right length so that you get a good contraction when you do decide to move them. That's what muscle tone is, and the descending part of the reticular formation helps with that. But the much more famous part of the reticular formation is the ascending part, and it's so famous that they actually gave it its own name. They call it the reticular activating system. And this system is super important in three things that I'm going to mention. First of all, it's important for helping you to maintain consciousness, staying awake. You can see on this diagram down here, this area in blue, that's meant to be the reticular activating system. And notice all these little arrows that are going up. All these arrows are going up to your cerebral cortex. The cerebral cortex is the part of your brain that conscious sensations have to reach, for you to be aware of them. If you block neuron signaling, a sensory signal, before it gets to the cerebral cortex, it'll be like you're not even aware of it. So in order to keep you awake and alert, the reticular activating system is constantly sending signals out to the cerebral cortex, like saying, hey, stay awake, there's still stuff to do, stay awake. Now, when you go to bed at night, you temporarily turn off the reticular activating system, and you essentially don't get all these signals being sent up, and you fall asleep. Okay? When you get up in the morning, though, it'll turn back on, hopefully, right? And then that'll wake you up. Once this turns on again, all these signals will be shot out to the cerebral cortex, and that will wake you up. A third thing that it's important for is filtering out insignificant information, like helping you to focus on a particular, object or a particular task, right? If you're the kind of person that when you take a test in here, you can hear someone else tapping their pen, or you hear that machine going on over there, it's probably because you don't have a good reticular activating system at filtering out all that other stuff and helping you to focus, okay? I'm right there with you. I honestly bugs the hell out of me, like who's tapping their pen, I can't stay focused. Another thing, and you might have figured this out, people with ADHD, attention deficit hyperactivity disorder, are thought to have problems with the reticular activating system because they can't filter out insignificant information. And there's kind of just this constant barrage of their attention kind of going in all different directions because they can't focus on one thing very well. Okay. When you go to sleep, you turn it off temporarily. If you have damage to this area of your brainstem, well, first of all, there's a good chance you could die from damage to your brainstem if you knock out one of those vital centers. But if you're lucky enough to not knock out one of the vital centers, you could still damage the RAS and kind of put you in a permanently unarousable state that we refer to as a coma, right? So that's like permanent damage. Over here is kind of illustrating the point number 2 about awakening us from sleep. And what this is showing you is that there are a variety of sensation types that send signals into the reticular activating system, which then will send signals up to your cerebral cortex that'll then wake you up. So to understand kind of this picture, all you have to do is think about the kind of things that would wake you up from sleep. So what can wake you up from sleep?
Alarm.
Alarm, right? A sound, right? And that's because your hearing sends signals into here, which then tell it to send signals up to the cerebral cortex. What else can wake you up from sleep?
Light.
Light, right? If the light's too bright, okay, and you can see that's because your eyes send signals in here, and then it'll send it up to the rest of your brain. What else? Touch, right? Things like your touch receptors, your Meissner's corpuscles, your Pacinian corpuscles, they send signals into the reticular activating system to turn it on, which will then send signals to the other parts that'll wake you up. What's notable about this, though, is what sensation is absent here? Smell, okay? Smell will not wake you up from sleep. All right. Now wait. I know some of you are about to say, "Well, when my husband like makes bacon in the morning and I'm still asleep, I like smell it, and then I get like really hungry and I wake up." No, you're already awake. All right. You're already awake. You're just you're just screwing around in bed, but you're already awake, or you're on the way to being awake. All right. So smell will not wake you up from deep sleep, and so what is it advisable that you have in your house then?
A smoke alarm.
A smoke alarm. So this is my big PSA. I got paid off by the fire department to give this speech. But yeah, you need to have a smoke alarm to basically convert it into an audio signal that'll then wake you up, right? All right, last, I got like 3 slides left. Cerebellum. Cerebellum is the second largest part of your brain. The word cerebellum means little brain because it looks like a small version of the cerebrum, which is the biggest part of your brain. It's got those weird sort of little worms and things that are on the outside. Notice anatomically, the cerebrum, and I mentioned this earlier on in the lecture, but the cerebrum is separated from, the cerebrum, which is up here, is separated from the cerebellum by this little groove here, and that groove is called the transverse fissure. And sitting inside that groove would be the tentorium cerebelli, which is an extension of the dura mater that kind of helps to organize the brain. So that's where that would be located. Now, if you look at the back of the cerebellum, so like right here in the middle, or you can see it on this picture a little bit better, there's something called the vermis. Anyone know what the word vermis means? Anyone, what does this kind of look like, this thing in the middle here? I think somebody said it. What does it look like? What'd you say?
Worm.
It's a worm. Yeah, vermis means worm, okay? Kind of looks like an earthworm or a segmented worm, all right? That's also the reason why the full name for your appendix, which is down there, is called the vermiform appendix. It means like the worm-shaped appendix, okay? Anyway, that's right in the middle, and that's how it got its name, vermis. There's going to be a left and a right hemisphere. Just like there's a big left and right cerebral hemisphere, there's going to be a left and right cerebellar hemisphere, okay? It really is like a mini version of the cerebrum. Connecting the cerebellum to the brainstem are these things called the cerebellar peduncles. So if you could look inside here, you'd find axons that are either like going into the pons or coming from the pons, etc. That's kind of the connection point. Another thing that's similar about the cerebellum and the cerebrum has to do with the gray matter and the white matter. Just like the cerebrum, the gray matter is on the outside, and then the white matter is on the inside. Okay. The little folds that you have on the cerebellum, those are called folia. That's a little bit different than the name they give for the cerebrum. In the cerebrum, they call those big folds that you see the gyri or the gyrus. We'll get into that later, but so that is one difference. The white matter, they kind of have a poetic name for it. I don't know who came up with this, but they call this arbor vitae, which means like tree of life. So that's specifically the name for this white matter because it kind of looks like a little tree that's spreading out, I guess, inside of the cerebellum. So what the heck does the cerebellum do? Think of it as a quality control center for your body movements, okay? When you want to move a body part, the idea for moving a body part actually starts up really high in your cerebral cortex. which we'll talk about on Thursday. But that's where the idea for body movement starts. That signal is going to be coming down, and as it gets to the brainstem, that signal is going to be sent into the cerebellum to tell the cerebellum, this is the movement that I would like to do. This is my plan. This is the movement that I want to have happen. At the same time that that signal is going into the cerebellum, another signal is going down your spinal cord and eventually out to your muscles to make the actual movement happen. You then do the movement, and inside of your muscles are sensory receptors, like the muscle spindles, the Golgi tendon organ, and they monitor the actual movement that's happening. And they send that signal back up your spinal cord, and they send that signal into the cerebellum. And now the cerebellum has two pieces of information. It has the movement that you wanted to do, and then it has the actual movement that happened. And if the two match up, great, okay? Probably means like you're good at sports or whatever. But if you're like me, they probably didn't match up. And so the cerebellum is then like, oh, let's fix the real movement so that it matches up with the intended body movement. So that's why I say it's kind of like a quality control center. So the cerebellum will send out extra signals and things to try to make it so that your actual body movement is matching up with your planned body movement. Okay? Cerebellum is also important for setting your posture and helping with balance, okay, so you don't fall over and things. Damage to the cerebellum can result in ataxia. That's an inability to coordinate your muscle movements. Anyone ever seen anybody with ataxia? I bet you have. You just didn't know it was called that. Let me ask you a different question. Let me ask you, has anyone ever seen anybody that's really drunk?
Yeah.
Okay, then you've seen somebody with ataxia, all right? Anyone here ever been pulled over for DUI? All right, no, you don't have to answer that. You don't, my attorney says you don't have to answer that. All right. All right, well, what do the cops do, right? They make you do all these stupid tests that are basically testing your cerebellum. Cerebellum is one of the first brain areas that's affected by alcohol. And when you knock it out, you can't perform coordinated muscle activity. So, they'll have you do some dumb stuff like, here, walk this line, and you're like try to do this as you're walking the line, right? You can't walk it. Or they'll do this crap, and we're like, I don't know why I sound like so angry about it, but they'll have you do stuff like that. When you talk, you're like, I love you, man. You're like slurring your words, right? Because you can't send signals to the muscles that make you talk clearly. So that's an area that definitely gets hit hard with alcohol. And most people, obviously, once you sober up, it was like a temporary ataxia, but that's an example of ataxia. Yeah, not doing it. Yeah?
Why do they do like the eye test thing?
Oh, they're looking for, like, other types of medications can cause your pupils to be like fixed or dilated so that they don't respond to light. Yeah, that's not really having to do with the cerebellum, but it is something that can be seen with like drug use and things like that. Yeah. All right, that's actually all I had to cover, so we did get out a little bit early. Any questions about any of that stuff? All right, please take the, you have a question?
It's very random.
Oh, that's okay.
In the RAS, like when people get put into medical-induced comas, do they tap into there?
Yeah, the drugs are really kind of affecting that area. Yeah, they hit that pretty hard. Yep. Please take some candy on the way out. Go vote. 2.
If I do it like 5,
I write the questions he asks us and the answer, and then I rewrite what is written as a question. So you flip them.